Yes, we're going to do something different this evening. I have 3 or 4 case studies in obstetrics for you.
Okay.
And instead, last week, we went over matching the particular words in the case study to the parts of the code, and we built the code. This time, you all are going to do that. So, if you need a minute, you need to have your PCS book, your code book, and then maybe I suggest a pad of paper and a pen.
Okay.
Okay.
I'm good.
Okay.
Let me get a pad. What happened to my pad? Hold on. I'm at my
They
cousin's
grow
house.
legs and walk away.
Oh, no. Oh. I got all kind of little notes in here.
And now you're going to have more.
I know. These are my notes from, which class is this? 216.
I was going to say last night with Ms. Johnson, right? Yes.
Yes. Then she told us, she said, don't worry about the, if you don't get the application right. She said, I just want you to learn to read. I said, 5 times telling us that.
I know. See, you know that book? Did you ever hear that book, Everything I Needed to Learn as an Adult, I Learned in Kindergarten?
Yes.
Coding proves that. You need to learn to read. That's it. Are you ready, Nikki?
Yes, I'm ready.
Okay. Jennifer's ready?
I'm good.
All right. The first one is the longest one. I thought we'd get that done, you know, while you were still relatively fresh. And it does have 2 codes, okay?
Okay.
So, and you tell me when you have, you know, gotten the information from this. And of course, the case study continues on the next slide. Okay. A red tip, I took out all of the header stuff and, you know, patient was supine on the table nonsense. All right. So a red rubber tip catheter was placed gently to drain the patient's bladder. A weighted speculum was placed in the posterior vagina and diva retractor anteriorly. A single tooth tenaculum was placed in the anterior cervix for retraction. The uterus sounded to 9 centimeters. The cervix was dilated with Hanks dilators to 25 French. This sufficiently passed a number 7 suction curette. The suction curette was inserted without incident, and the products of conception were gently suctioned out. Good uterine cry was noted with a serrated curette. No further products were noted on suctioning. At this point, a Hulka tenaculum was placed in the cervix for retraction. The other instruments were removed. So we know that. What tells us what section of the ICD-10 PCS book are we going to be looking in? What's the first thing?
The products of conception.
Yeah.
Very good. Excellent. So we know that this code or these codes are going to start with the number 1.
Yes.
Okay.
I've got a question. I've got a question about that before you say say number 1. Now, I thought there was 2 different ways to code abortions. I thought if it was voluntary, it's considered surgery. Am I thinking wrong?
Not an ICD-10 PCS.
Okay, I thought I read in our book that it said if it was not voluntary, meaning it was for medical purposes, it would be under abortion under obstetrics. But if it was a voluntary thing to just have an abortion, and it was considered part of surgery. I might have read it wrong then. I'll go back and find where I read that. Now,
Please
okay.
do, because
Okay.
I wrote it, and that doesn't
Okay.
make any sense to me.
I've read it. I thought I read it in our book. I'll reread it. I may have read it wrong.
And remember, yes, with PCS, we're looking for the procedure. So
Right.
intent has nothing to do with it. What are
Right.
we looking
Okay.
for? We're looking for products of conception.
Mhm.
If products of conception are involved in the procedure in any way, it's 99.9% in obstetrics. Okay.
I found the phrasing. But I see what I missed.
Okay, good.
It's because a voluntary abortion is usually done on an outpatient basis.
That's very true.
Okay. So now my brain is right again. Okay.
Okay,
Sorry.
good.
Continue.
But whenever your brain, goes askew, you remember you need to ask me so you did the right thing. Okay. All right. So we have products of conception were involved here.
Yeah.
And the two listed procedures on this op report were dilation and curettage with suction.
Yes.
And then laparoscopic bilateral tubal ligation using Kleppinger bipolar cautery. Okay, so we know that this procedure that we just read about was which one?
Oh, the dilation.
Yeah.
Yeah.
Right, and you have those words here, right?
Mhm.
You have the dilation, you have the products of conception being suctioned out.
Mm-hmm.
So that absolutely has to be from the obstetrics section of ICD-10 PCS. All right, so we have, one, and then the second character for pregnancy is what again?
Oh, 0 for pregnancy.
0.
Okay, 1, 0, and then what's the root operation for this dilation and curettage?
Hold on.
It would either be abortion or extraction, but doesn't that depend on what?
Wouldn't it be extraction because of the suction?
Okay, there you go. Yeah, you got it, Nikki. I was getting ready to ask if it was because she had already had, if it was a difference between already having lost part of it and removing the remaining products of conception, but it doesn't say all that in there. I like your answer, Nikki.
Kenyatta, you get to speak up too, Okay, so let's take a look for a second. Let's take a look for a second, and we see that abortion, the root operation term abortion, is defined as artificially terminating a pregnancy.
Yes.
And extraction is pulling or stripping out or off all or a portion of a bodily part by the use of force. So which do you think best describes what is stated in this documentation?
Abortion? Would it be abortion?
I heard a question mark at the end of that. I don't want you to question me. I want you to tell me.
With confidence. Abortion.
Okay, let's go with that. Okay, so if we go 1, 0, A, 0, which is your body part products of conception, what would the approach be?
7, the natural or artificial opening.
Correct.
Yeah.
What's the device?
No
No device.
device.
And then what's the qualifier?
Would it be, the suction be like a vacuum?
Yeah, vacuum.
Yes. All right, so I'm going to switch to this and let's see. We have OUD, extraction, endometrium. No, that's
not
not
right.
right.
Mm-mm.
That's not right. So let's fill in ours, okay? So we have 0, which is obstetrics.
I thought 1 was upset.
1.
Oh,
Yeah.
you're right. Thank you. I did that on purpose to see if you were paying attention. And then we have 0
For
for
pregnancy.
pregnancy. Okay. And then we have the root operation term. And you know, I have to tell you, I agree with you. I may have endometrium. Yeah, I don't like this. Yeah, I think this is much better. So then we have A for
abortion.
abortion.
Mm-hmm.
And what happened here? Okay. What words, how did you determine this is by the definition, right?
Yes.
Mm-hmm.
Okay, so I'm by definition. Thank you. All right, and then we have 0 for, oh gosh. 0 for products of conception.
Yeah.
And that's stated directly in the documentation.
Mm-hmm. Yeah.
And then we have 7, right?
Yes.
Which is via natural.
Mm-hmm.
And I don't know why it keeps doing that. And then Z for no device, because nothing was placed in that wasn't taken out.
Yeah.
And then we have 6
for
vacuum.
Mm-hmm.
I think that's excellent. And we're going to say suction.
Yeah.
Okay. So do you all feel very comfortable with this? Do you have confidence?
Yes.
Yes.
Kenyatta? I'm sorry. I had another student, Kenyatta. Kenyatta? Hello? She left me flat. Okay. There you are. Yeah. Kenyatta. What do you say? Okay, fine. Don't talk to me.
Now,
All
are
right.
you recording this?
I am.
Okay.
All right. All right. So here's the next paragraph about the second procedure. Attention was then turned to the patient's abdomen. A small vertical infraumbilical incision was made with the knife. A Verus needle was placed through that incision. Confirmation of placement into the abdominal cavity was made with installation of normal saline without return and a positive handing drop test. The abdomen was then insufflated with sufficient carbon dioxide gas to cause abdominal tympany. The Verus needle was removed and a 5mm trocar was placed in the same incision. Confirmation of placement into the abdominal cavity was made with placement of the laparoscopic camera. Another trocar site was placed 2 finger breadths above the pubic symphysis in the midline under direct visualization. The above noted intrapelvic and intra-abdominal findings were seen. The patient was placed in steep Trendelenburg. The fallopian tubes were identified and followed out to the fimbriated ends. They were then cauterized 4 times on either side. At this point, all instruments were removed from the patient's abdomen. This was done under direct visualization during the insufflation. The skin incisions were reapproximated with 4-0 vicryl suture. The Hulka tenaculum was removed without incident. So here we go. Now, the first question I have is, what section of the ICD-10 PCS book should this be?
Med-surg.
Yeah, med-surg.
Very good. Okay. And the second would be, what body system?
Female reproductive.
Yep.
Yes. Which is after, isn't it after? No, it's before the male. Okay.
It's you.
Yep.
It's me. I am a female. You were correct. It's you. It's you. Okay. All right. Now, what exactly was the procedure here?
It is occlusion because it's a tubal ligation.
Excellent. So we go to occlusion, which is
L.
No, the best thing in the world.
okay. So we have OUL
Uh-huh.
and the body part
Fallopian tube, bilateral.
bilateral. Good. So that would be 7.
Yes.
OUL 7. Was this, what was the approach?
Percutaneous endoscopic.
Endoscopic.
Very good, because
Yes.
that's what PCS calls laparoscopy.
So that's 4.
So 4. Then what device was used?
It was D. Hold on.
The fallopian tube, look, I'm pointing like you can see. The fallopian tubes, it's toward the bottom, like the last bottom third. The line starts in steep Trendelenburg. The fallopian tubes were identified and followed out to the fimbriated ends. What end is that? The end that that's over by the ovary, or the end that is where the uterus is?
That's by the ovary.
Ovaries.
Very good. They were then cauterized 4 times on either side. Cauterized. At this point, all instruments were removed from the patient's abdomen.
So it's C.
So no device. C.
No device?
D.
Okay. Z.
Correct.
Okay.
No
I got it now.
device.
And then no qualifier.
No problem.
Yep.
Okay. So, whoops. Let's go to, let's see what we have here. OUL 7 for ZZ.
Yes.
Yep.
Excellent job, ladies. And this is hard. Now, when you guys get out into the real world, you may be reading documentation on the computer. Okay. If you are working, particularly if you're working remotely, you will get access to the EHR via your computer. But just remember that if you use your finger to point to each word, even though it's on your screen, that will help you get the information you need. Okay.
Okay.
You may or may not be able to print it out. It's going to depend on your particular facility and their rules. Okay. Because why? Why would they not want you to print it out? What, that could be a violation of
HIPAA.
HIPAA.
Exactly. Okay. Good job. All right. Here's an easy one for you. A baby was born. How nice. We're coding for the mother. So what do you think the section of ICD-10 PCS should be?
It would be obstetric. I can't talk right now. I know it's a 1.
Obstetrics.
Obstetrics.
Obstetric.
You
It's
are
a 1.
correct. It's a 1. Okay. We automatically know the second character is going to be a 0 because it always is in this section, pregnancy.
Yeah.
The root operation term.
It's going to be delivery.
Delivery. Yeah.
Very good. And that kind of takes away any more definite decisions that you have to make, because
Right.
there's only one choice over each of these codes. And let's see if we have it correctly. 10E 0XZZ. Did you get
Yep.
it?
That's what we got.
Yeah.
See, you're always going to get an easy one at some point. Okay. Oh, I was wrong. This one is longer. Okay. Oh, but there's only one code at the end of this. Okay.
Okay.
Are you ready?
Uh-huh.
All right. Extra points to anyone who identifies the name of this patient from what television show?
Oh, goodness.
Do.
Is that the Roseanne show?
Very good, Roseanne. The Roseanne Show. Roseanne Harris was the lead character's name. Okay. In the 41st week of her first pregnancy, a 37-year-old woman arrived at 6:30 a.m. for a planned induction of labor due to mild pregnancy-induced hypertension. The mother's blood pressure was 176/95. Yikes. But the nurse thought this was related to nausea, vomiting, and discomfort from the contractions. The resident examined the mother, determined that her cervix was 5 to 6 centimeters, 90% effaced, and the vertex was at 0 station. An internal fetal heart monitor was placed because the mother's vomiting and discomfort caused her to move around too much in the bed. Okay, making it hard to record the fetal heart rate with an external monitor. The internal monitor revealed a steady fetal heart rate of 120 and no decelerations. Okay. You know, I think there's a okay. All right. Do you need any more time with the screen?
No.
No.
Okay. Continuing. The primary nurse noted in the labor record that the baseline fetal heart rate was, quote, unstable between 100 and 120, but she did not report this to the resident. Damn. The nurse recorded that the fetal heart rate was flat no variability. As the nurse was documenting this as a non-reassuring fetal heart rate pattern, the patient expressed a strong urge to push, and the nurse called for an exam. A resident came to the bedside, examined the mother, and noted that she was fully dilated with the caput at +1. A brief update was written in the chart, but the clinician who had performed the exam was not noted. That means his or her name was not noted. The mother was repositioned and began pushing.
Mm.
The fetal heart rate suddenly dropped and remained profoundly bradycardic, which is what?
Slow heart rate.
Slow heart rate.
For 11 minutes.
Mm-mm.
The resident was called and attempted a vacuum delivery since the fetal head was at +2 station. The attending then entered and attempted forceps delivery. An emergency C-section, Caesarean delivery was performed. The baby was stillborn. The physician identified a uterine rupture that required significant blood replacement. Oops. Sorry.
Malpractice suit.
Oh, yeah.
Yeah.
And the first one that I'm sending to jail is that nurse.
That nurse,
Okay.
That nurse is going to get it.
That nurse needs to get it.
Yeah.
Bam. Ugh, I just honestly don't understand that.
Mm-mm.
Okay. Right? I mean, even in self-preservation, the nurse is going to get in trouble. The mother's not going to get in trouble. Your fetus was not stupid. Anyway. All right. So what are we coding here?
The cesarean delivery.
Yeah.
Let's start there. Okay. So we got 1 for obstetrics.
Yep.
Okay. And we got 0 for pregnancy. Obstetrics, not obstetrics. Okay. What's next?
Extraction.
Extraction, D.
Very good. Extraction. And then
Products of conception, 0.
0, correct. Okay.
Open.
Yeah, open.
Open, so
Open,
0.
very good.
No
Next.
device, so it's Z. Z.
And last but not least, where was now this is, we're going to go back and take a look. Well, I think this might be the emergency cesarean delivery was performed. So in real life, you should have, you would have to query the physician to find out where the incision was. High, low, or extraperitoneal. So what do you guys say?
I was thinking low because of how far the baby down.
So high?
I was going to say high.
High?
They would cut high because the baby was low?
I would think low because the baby was lower.
Low because the baby was lower.
Because the baby was almost coming out.
Right. Okay. Or what does extraperitoneal mean?
Mm.
Somebody Google it.
Outside the peritoneum.
Yeah.
Very good. Yes,
yeah.
outside the peritoneum. But I don't know, would that make, I mean, it's a choice here, and we know that this is going to be a C-section. Somebody Google it. Put extraperitoneal plus C-section and tell me what it tells you.
Okay, hold on.
Ooh, that's little tiny print. Hold on. Says extraperitoneal cesarean is a method of surgically delivering a baby through an incision in the lower uterine segment without entering the peritoneal cavity.
Well, that's what you said before, outside the peritoneum. So what do you think we should do?
Query the doctor.
Very good. Yes.
And it says this is not a routine method.
It's not a routine method, but this was an emergency C-section.
Yeah.
So we don't know. I mean, we cannot even apply common sense or knowledge that we have. So we have to query the doctor. Let's see what the answer was in the answer key.
Classical, which is high.
High.
Yeah, but classical is high.
That's what it says in the book.
Yeah.
Oh, wait, I wrote the book. Yes, I think I should know. Okay. All right, I have another question for you. Where is it? It was, I think it was here.
Talking
There
about the
it
heart
is.
monitor. That's what I was wondering. Yeah.
Do you think that should be reported?
Yeah.
Well,
Of course. Yes, you are absolutely right. So, let me just take a copy of this. So wait, I want a copy of this one. And tell me what the code is for that. Okay, so we have one, which is obstetrics.
Mm-hmm.
Okay, and we have zero for preggers. And then what?
insertion.
Yeah.
Yep.
That'd be H.
Yeah. H.
Very good. And then what's, well, it's always products of conception.
Yeah. And it'll be 7.
Yeah, 7 because she hadn't been cut yet. That's
Yeah.
Right. Very good.
And then 3.
Mhm.
And what does 3 report?
The monitor and
Monitoring.
electrode.
Very good.
And then Z.
No qualifier.
Mm-hmm.
Very good. Good job, you guys. All right, you ready for one more?
Yes.
Sure.
Okay. C-section. This is a 26-year-old G1P0, which means
First baby.
First baby.
first baby and first pregnancy.
First pregnancy.
Yeah.
Yeah.
Right. She's O positive, VDRL-NR, rubella immune, HBsAg negative female at 27 weeks of gestation, presents to labor and delivery with a 2-day history of headache and facial swelling. Wow.
Mm.
Maternal history is remarkable for a single prenatal visit in the first trimester. Uh-oh.
So she hadn't been to the doctor.
No, not since she first got pregnant.
Mm.
Shama. Okay, exam, VST 37, P75, R14, BP 170. Whoa, no wonder she has.
Wow.
Mm.
Her exam is remarkable for facial and pretibial edema and hyperreflexia. Urine dipstick positive for 3+ protein. Ultrasound demonstrates decreased, amniotic fluid. The fetus is in the breech position and no fetal abnormalities are noted. Estimated fetal weight is 650 grams. A decision is made to deliver the infant by cesarean section following maternal treatment with beta-methazosone sodium phosphate 0.5 milligrams per deciliter. Labor and delivery occurs without incident. Infant taken to the NICU, neonatologist is paged. Mother is taken to recovery in good condition. Wow. Or at least this one has a happy ending.
Yeah.
Yeah.
Okay, so we have 1, 0.
D.
D as in extraction.
Extraction.
Mm-hmm.
And then
0.
0 for products of conception. Approach.
Open. So 0.
Device.
Z.
Z.
And again, we do not have specification with regard to where the incision is. So let's see what we got here. We got 1, obstetrics. 0, pregnancy. D for extraction. All right, what did you say the body part was?
0.
Products of conception. 0.
Well, you do have other choices, so I have to make sure. Okay. The approach?
0 for open.
Open.
Z, no device. And what are we going to do for this qualifier?
Can we say 0 for a classic?
It said classic,
No, it didn't give us anything.
so we have to query the doctor.
Yeah.
That's it.
So we query. Oh,
Yep, you've
that's
got a
smart.
query. Okay, let's see what it was in the answer key. High was chosen for that. 1DOOZ 0. But I think you guys are correct that the right thing to do is query the physician. And remember, anyone might say, well, what's the difference where the incision was? You know, they're getting paid for making the incision and taking the baby out. What's the difference whether it was high, low, or extra peritoneal? And can either one of you tell me why it would make a difference?
Wouldn't it affect the reimbursement?
It might.
Yeah, but if there wasn't a difference, they wouldn't have anything there. It would just say no qualifier. So there's some difference.
There is a difference, but in addition to potentially being reimbursement, there's more of a difference for continuity of care.
Okay. I was say infection. I was going to say maybe infection.
Yes. What if the incision gets infected, or maybe she gets pregnant again in a year from now, and they say, well, if we do another C-section, we can't do it in the same spot or whatever. The fact is that we don't really know, but yes, Jennifer made an excellent point that they would not be collecting the specific data if it didn't matter, right?
Right.
We see this, and this is a good example of extraction because we coded earlier this evening extraction, and it was an abortion, right? It was dilation and curettage. So in that case, the products of conception were very early, as opposed to this being a a premature, albeit fully formed fetus, right? But they didn't seek to ask for that differentiation. Isn't that interesting? So, and that's exactly the bottom line, the reason for these expanded code sets. You might not have had any exposure to ICD-9. We switched to ICD-10 back in October of 2015. But these codes, both ICD-10-CM, what you're doing last night with Ms. Johnson, and PCS, are incredibly longer than their predecessor codes. And the reason for this is to enable the collection of more specific data that will help us not only provide better continuity of care, but also alert us, the healthcare system in the United States and maybe even worldwide, to particular concerns or problems with a particular procedure or diagnosis, or relationship between a procedure and a diagnosis. Just because there's a procedure that's done a certain way doesn't mean that that's the best way, even if it's the most common way. So it's very important that we gather detailed data so we can crunch these numbers and say, okay, here we had 3 deliveries today. 2 of them ended up being C-section. Only 1 of them was vaginal delivery, right?
Yeah.
So it's important that we remember that the specificity asked for by the code set, whichever code set it is, has been delegated or identified as important specific data for the betterment, the improvement of care to patients. And if we, and we're the interpreters, right? We take the physician's words and we interpret that into a language that a computer can crunch the numbers, analyze very quickly. So now research analysis can take maybe a couple of days, as opposed to back in 1970, when all of this analysis had to be done by hand, by people. People had to go through paper records and, oh, here's one.
Wow.
Okay, here's another one. Okay, well, here's another one 5 hours later. Okay, now, because of us, we can interpret the words into the very specific information. And do not think that just because the doctor didn't include that specific detail that it's not important. Because you know how it is, right?
Yeah.
Is you know something so well, you go, well, of course in this situation I did a high incision or a low incision or an extraperitoneal incision. You know, I didn't have to write it down because it's a no-brainer, right? Except the problem is that the documentation is not only for that one physician. So we have to have the details. When you identify something and you say, there's nothing here, we must query. And it's important that you understand the importance of this, not only for this one case, but when you can go to the physician and say, I need to have you document where was this incision made. And you can give them a multiple choice test. I mean, you know, question,
Mhm.
you can say, was it high? Was it low? Was it extraperitoneal? So, you know, and it makes it easier for you then if they don't go into some long, description. But it also teaches that physician that this information has to be included in the patient record, not only for coding and reimbursement, not only for research and data collection, but for continuity of care. And that's the way we teach them. You know, they never took coding. They don't know how to code. They don't know how to do any of this. So it's very important that we help them understand we're a team together. We work together for the patient, not only in the operating room, but in reimbursement, in the facility, for the next time this patient goes to see the doctor or another doctor or whatever throughout their life. Does that make sense?
Yes, ma'am.
Yes.
Good. Because I want you to understand that when you go out there and you start working in the real world, you may encounter people who are lazy or who don't know any better. And my most hated sentence, hearing this sentence, is literally my entire life has been my most hated sentence, which is, well, this is the way we've always done it.
Yeah.
Okay. Well, then you go back to the operating room and pour ether on the patient's face and see if you can't sharpen a stone so you can cut into the patient. The point is to move forward and make things better. Okay.
Mm-hmm.
So that's why I'm trying to help you understand the intellectual purpose of querying the doctor and the forward thinking of this to help improve things, because just because that person sitting next to you or in the next cubicle has been here for 5 years or 20 years does not mean they know more than you.
Now, when you query,
Mm-hmm.
do you give them the questions, the multiple choices that they can choose? That when you do it, like some of the program or whatever you're using will probably send it out for you. Is there a time frame for the doctor to return it? Does it give the doctor a time frame? Do you give the doctor a time frame, or do you just wait?
Excellent question. If you just wait, you might be waiting until 2025. So most hospitals have a policy about that states that the physician has to respond within 48 hours or 72 hours. So that's one good question that you need to find out.
Okay.
In that facility, okay? I suggest, knowing that, let's say it says 72 hours, because we can't expect immediate response. The doctor's busy doctoring, right?
Yeah.
So I would suggest adding that onto the query itself, but not within 72 hours. I would actually put your response by Thursday, September 17th, 5 p.m. would be very much appreciated.
Okay.
Okay. Or something like that. All right.
Okay.
The reason for, and this is something I learned very early on when I had my own business, is nobody knows what that means. In 48 hours, okay, let's say 48 hours. Now, y'all can say, yes, I'm an intelligent, educated person. I know 48 hours is 2 days. No, that's not what I'm saying. What I'm saying is, when does the clock start? 48 hours from when? From when you sent the query? Or 48 hours from when the query was received in his mailbox, inbox, whatever? Or 48 hours from when he read? Okay, right there, that could be a difference of 10 hours.
Yeah.
Yeah.
So my point is you can say, well, you need to answer within 48 hours, but yes, that's fine. It's a good measurement, except without a start time, you have no idea what the end time is. So it's much better to be precise.
Okay.
And you do the 48-hour clock yourself. And then you can also fudge it a little bit. Okay, and what I mean by that is, let's say from the time you're creating this query, the hospital policy is 48 hours, but 48 hours would put it at midnight. And you're not going to make a big deal to this doctor at midnight. You're home in bed. You're not coding this. So you could then say by 9 o'clock the next morning.
Okay.
Okay. And you can make that allowance. And then doctors will come to realize that you are a reasonable person.
Okay.
And then hopefully that will promote a better give and take working. Now, in a physician's office or outpatient, it's a much smaller enterprise, so you'll have fewer doctors to deal with. Then well, first of all, you need to check and see what their query policy is. You may find the facility doesn't have a query policy, which means you need to set it up.
Okay.
And if I was setting up a query policy, the first thing I would do is go to each physician and say, what is your preferred method of communication? If I have a question about a patient record, some documentation, I have a question I need to get answered so we can code this, get the claim out, and get money coming in. What do you prefer? Do you want me to put a note on your desk? Do you want me to send you an email? Do you want me to send you a text message? Do you want me to send you a text message to tell you I sent you an email? What? Do you want me to make an appointment to be your last appointment of the day, and then we can just discuss them face to face?
Now, even discussing face to face, wouldn't you like to have something in writing and a signature so that you can have proof?
Yes. So when I say face to face, I mean you're sitting on one side, the doctor is sitting at his or her desk, and they should have the EHR open, and then you say, I need to know what kind of incision this was for the C-section, and say, could you enter it right there now in the record?
Okay.
Okay. But when I say face to face, it's you and the doctor are face to face, but the answers, yes, need to be documented.
Okay.
Okay. This also means seeing the doctor and walking down the hall together. You can say, can you tell me what the incision was? But I don't like that, because as you both pointed out, there's no documentation. And we all know if it's not documented, it didn't happen. If it didn't happen, you can't code it. Period. Finished. Thank you very much. So it's best. And honestly, so the doctors, and they are very important. I mean, we're important too, but the doctors are very important. Okay. So therefore, I think it makes more sense for us to be flexible and to provide this communication in the manner that the physician prefers. Because I'm sure you know people who, oh, I sent you an email about that. And they go, email? I haven't looked at my email box in a week.
That sound like me.
Yeah.
Okay, see, excellent example.
They
Okay.
be talking about that at work, Bill. Did you see the email? I'm like, no, I didn't see no email.
So that's Nikki, you're a perfect example of what I'm trying to say.
Yeah,
Okay.
because I missed the meeting at work. Did not know because I did not look at
You
my
did not
email.
check your email. See what I'm saying? Now, for me, if you want me to come to a meeting, I want the email and I want all the
Yeah.
details in the email because then I may print it out or then I put it on my calendar or whatever. Okay. So that's what I'm saying. We have so many different ways to communicate, but if you don't connect with the way somebody communicates,
You won't get through.
you
Right.
won't get through. You won't get to the meeting. You won't know what's going on because right, exactly. So even if they have a current query, you might talk to some of the people that are there and say, what's your response time from doctors? And if they go, query, what's a query? Then you know you got your work cut out for you.
Mm-hmm.
But we know it is proven you got to query. I had a student who was at a previous school. We used to have internships, on-site internships for our students. And she came in to school. I was teaching face-to-face. And she came into school and she said, I got to tell you, I said to the woman, the other coder who was working with me in the office, and I said, well, what's your process for querying the physician? And she actually said, oh, we don't query, just make something up. It doesn't matter.
Oh my gosh.
Yeah, that was my response exactly. And then I said, and some internships are excellent ways to learn what not to do. Ugh. Okay.
Because when I did the program, I did the medical coding program in 2008. They first started the program at Central,
Oh.
and I have the ICD-9 books.
Mm-hmm.
And we had externships outside. So
Uh-huh.
I went to I was in Lugoff at a doctor's office, and they give you this whole stack of the what they get when they check off the different things,
Mm-hmm.
but why they're
Oh,
there.
the
Um,
super bill.
Yeah.
They
Yeah.
hand you this whole stack of super bills. First day I got there, a girl, she came in, and she told me, she said, okay, I'm leaving, so I'm not gonna be back. And she gave me this 3-day orientation.
Oh my gosh.
So I had to go through, and there were plenty of times when you couldn't even read the doctor's handwriting, but all of them were there, and they were very nice. The doctors were very nice. The office managers were very nice. They help you figure out the doctor's handwriting. But I mean, it was like I was in this room by myself with this big folder full of stuff because and I did it. I put the stuff in, and the lady who does the outs, they just start doing the coding outside of the office, and then she would come in and go over them to make sure that I was doing it right. And she would end up coding, and I had the majority of them right. Right. So it was like I did her work, and she can't pay me for it. But it was something going to these offices, and it was a lot.
Yeah.
It was nice. They were nice. They were very nice.
Well, that's good. And you know what? Most of them are. And I think even, you hear stories of doctors kind of going, go away, kid, you bother me. I don't have time for that. I have patients to see. But when you, I think, approach them with respect, and like I said, as, we're all part of this team, and you want to get paid, don't you? Because
Yeah.
Yeah.
I'm the one in control of the money. Okay. All right. What questions do you have?
I actually have an ICD-9 question for you, because now that y'all are talking about the ICD-9, I have seen on some of the job boards that they say they want you to know ICD-9, ICD-10, and I'm like, you shouldn't be billing from ICD-9 anymore.
No, nobody should. Nobody anywhere in the entire world, by the way. But here's my opinion about that. Because of
Okay.
course I have no way of actually knowing, but
Yeah.
I have seen this also. I have seen this in when I do curriculum consulting,
Mhm.
and they'll give me the description for the program or the code, and they go ICD-9. What the heck are you teaching ICD-9 for? So
Yeah.
here's my opinion about that. My opinion about that is they're using a job description that was written in 2012.
Okay, that's pretty much
And
where I
they
was
just
leaning.
never
But yeah,
updated it. And I'll tell
yeah,
you why they probably never updated it, because the human resources person don't know griddly what.
right. They don't know anything about it. Yeah.
No, they don't. I'm working
Okay.
on this research project with these people from Johns Hopkins,
Mhm.
and they these measures for this research project, and we had a whole discussion which I started because they had some ICD-9 codes in there, and I said, you know, you really want to go back that far? And we're going to leave them because they said some hospital administrators may want to do a 10-year study, but the
Mm.
chances are they won't be used. But I mean, it's on a piece of paper. It's, it's not taking up
Right.
that much room. But no, my belief is in those job descriptions, it's just because people who don't know what they're doing didn't bother to update their the job description.
Okay. Because see, I suppose I knew we would not be billing from ICD-9 ever, but I didn't know if it was something. Maybe if you're uh, the auditor or something, did you need to know anything about ICD-9? Because I know that's 2015. I mean,
And
would
it would
we even
actually
really be
be,
auditing?
yeah,
Yeah.
exactly. So yes, I would say this is, if you were doing an audit or
Mhm.
in that position to do research,
Mm-hmm.
then I would say two things. Number one, I would ask the question and say, I can do this, but are we going to be doing auditing going all the way back to 2015?
Okay.
And that'll make you sound very smart, by the way. And so again, I really think the other thing I wanted to say is, if you got an answer that was yes, we sometimes do audits all the way back to 2014, 2015, then
Mm-hmm.
I would say, great, no problem.
Right.
And if you know how to code out of ICD-10
Mm-hmm.
CM, you will have no problem encoding out of ICD-9.
Okay.
Okay. And you know that I and Miss Johnson are always here for you.
Okay.
Because
You, Nikki, yeah, we are your teachers for life. So no matter where you
I
go,
am so glad you say that, because the one that we had before, it was like, afterwards, it was, she was reachable for a second, then she just dropped off the face of the earth. And
wow.
when I tried to reach out to her after a while, don't like one of my classmates, she started working at Carolinas, which is now MUSC Florence.
Mm-hmm.
Um, and our instructor, she was working there with her, and they talked and stuff. But when you try, after she left, because I reached out, because I was trying to reach out and find out about the program, because I didn't take my boards. So I wanted to know, well, what can I do? Is there any kind of refreshment, or do I have to start over because now it's ICD-10 and not 9? Because when I finished, ICD-10 was getting ready to start that following year.
Mm-hmm.
And they said I could still take my boards for 9, but
Yeah.
I wasn't confident. So I was like, well, wanted to know if there was anything that she could help me, with, do I need to take the AHIMA? Do I need to take the other one? Which
Right.
one should I take? And it was like she kind of just tossed us, and she changed. We could use her as a reference, and then all of a sudden her phone number changed. She moved,
Wow.
and it was
There's a possibility, and we had this when we were transitioning from 9 to 10. We saw this throughout the industry. There was a segment of professionals who said, "I'm not learning anything new. Forget about it." And they just left the industry because they did not want to learn ICD-10. The sad thing is, and I don't see you or Jennifer or Nikki, I don't see either one of you having this attitude. And if you develop it, you let me know, I'll come kick your butt. But the fact is that this is a profession where you always need to be learning new things. Plus, learning new things keeps your brain cells young and healthy. Okay?
Mhm.
So learning new things should never shy you away from something. And my opinion was for people who said that, who said, well, if we transition to ICD-10, I'm taking early retirement or whatever. And my feeling was,
Yeah.
bye-bye. We don't, who wants people like that in this industry, especially this part of this industry?
Yeah.
Could you imagine?
She was mainly pushing us to get our RHIT,
Uh-huh.
and more than anything else, she kept
But the school, you weren't qualified to sit for the RHIT.
she was trying to push us to get into the program at Greenville, to
Oh.
do it, and to go online or to get our bachelor's in it. And it was like, but right now I want to be able to work in this field. So I
That's the
wasn't.
good thing. That's the good thing about this is here you can get your certificate, even get an associate degree, work up to a bachelor's degree, whatever. I know you've already done more than that. But you can go out to work as soon as you finish these classes because then you'll be ready to sit for your certification. And that proves your readiness to work in the field. And then all the additional education will help you if you want to move into managerial positions or take on additional responsibilities, or like you guys have done. I know Jennifer, Nikki, did you already do the outpatient with CPT and everything?
No, what I did was I like I was talking to Jennifer. um as of a month ago, I was writing my dissertation.
In what,
My
by the way?
I was going to Grand Canyon University online. I was
Uh-huh.
getting my EDD in healthcare administration.
Oh, your EDD.
Hmm.
Okay. My PhD is in healthcare administration.
So the thing was, when I went, because I liked the medical coding, I went for my master's at Grand Canyon, and I got it in. The closest I could get was healthcare informatics.
Oh, same thing.
Yep. So I got healthcare informatics. So started that. I finished it, got my master's, and I let my recruiter talk me into going for my doctoral degree. I told her that if it didn't, I wanted it to. I said, I really don't want to be CEO leadership like that. If I have to, I'll be a supervisor. I said, but that wasn't, oh, well, you can do this, and it blends. I say, okay. So I have been in the program 5 years. I've finished all of my classes, and I was writing my dissertation. Just had a year ago my second residency, And when I went to my second residency, I had my professors there told me threw everything out and I had to start over. So I got my chair.
Oh!
When I got home, start everything all over again. Met my chair, and he went through it and threw everything out, and I had to start over. So I got to the point where I got all that accepted, and I was doing my first 3 chapters of my dissertation for my what they call it, so I can submit it in order to go further on.
Right.
Yeah.
Well, here's the way I describe my
Health-wise,
dissertation.
it drove me crazy. Health-wise, my health started going down, and
I
everything.
describe the dissertation process. Took me 2.5 years to finish my dissertation, and I describe it as crawling naked over broken glass.
It truly is.
Oh my gosh.
Mentally,
Yes.
I got diagnosed with ADHD, mild depression,
Oh my
my
gosh.
blood pressure, it messed with my thyroid levels started going out of whack. It was just mentally and physically, health-wise, I had to make a decision. And I've always wanted, it got to the point where I was saying, well, can I go back to coding? I said, I want to do it. That's how I talked to my mom, and I told her, and the main thing was I felt that I was going to be a failure. And so that I had dropped the program. And so my mom told me that I wasn't a failure. I had succeeded a lot, and just to be, she's proud of me. So when she told me she was proud of me,
it's all okay.
Yeah, I called the school, and Ms. Johnson called me back that same day, and she got me accepted into the program. I didn't have to retake any of my stuff, and I got accepted right into. She held one of the 2 spots she had available for 216 and 225.
Hey.
Yeah. And then I met Jennifer. We the same age, and our birthdays. Her birthday the 20th of one month, and my birthday the 20th of the other month.
No kidding. What months?
I'm July.
And I'm May.
I'm May 29th.
Hey, cool.
Oh, you are a Gemini like my niece.
Oh yeah, baby. Oh yeah.
I am born the last day of Taurus.
Of Taurus.
11:59 p.m.
Wow. And Jennifer's a Cancer?
I'm a Cancer.
Yep.
All right, you guys, let me turn off let's all go get some dinner, okay?
I'm gonna ask one more question.
Okay.
And if you want to wait till next week to answer it, we can do that. Okay, hopefully. Okay.
Okay.
Because I'm already working in chapter 35 and went through the measurements and monitors and stuff. And
I haven't finished it all, but
there's a code talking about checking temperatures. So it made this question pop into my mind. Okay. I know that room and board in a hospital encompasses a lot of things. Okay. Where you don't have to individually charge for each thing. But do we have to charge is there some kind of line they draw?
Vitals?
Yeah. I mean, stuff like that. That's what I'm saying. It was like taking the temperature. I'm like, I would have considered that part of room and board. Why would we even need a code for it?
There is no code for it.
Well, it was a question we had to code for taking a temperature. In the measurements, the monitoring and measurements. Let me see. Let me get my.
You may be taking it out of context. But there had to be more than that. What did you say is monitoring?
Here it is. It's Cynthia Yackey. A 9-year-old female is admitted to Westford Hospital with an unexplained high fever. Dr. Hamilton measures Cynthia's temperature.
Is that in the
Really?
book part or on the?
Yeah, that was one that's in the You Code It Practice for chapter 35.
Okay, what page?
Well, see, my book's different than yours. I got an older book. Mine's 1081, but yours is probably different.
And you said it's on the You Coded?
Yeah, the You Code It Practice. It's number 5.
Okay, hold on. Okay, I see it. Said the unexplained high fever. And you gotta measure,
Yeah, it says Dr. Hamilton measures Cynthia's temperature.
yeah.
But there's no, what body system would you use for that?
It says none. It says it's
No,
under
it doesn't have any.
4A0, and then the body systems is there's only 2 options: products of conception, nervous, and then none.
No, 4A0 measurement,
Mm-hmm.
it has body, physiological systems, body systems, the 4th character, central nervous system, peripheral nervous, cardiac.
And which one would you pick? What was the?
Well, I'm telling the answer if I say the answer.
It's okay. Nikki would find it out on her own.
Yeah, 4A0 ZXKZ.
4A.
Oh, I see. None is at the very bottom.
Mm-hmm.
Oh, external temperature.
Well, it's the answer. Yeah, it's external. Yeah, I was thinking, and that's 2. I was thinking, wouldn't that be natural opening? Because you pretty much the best ways to take the temperature is the mouth and the behind.
Yes. Actually, I agree with you.
Because that was what I put, but the correct answer said it was external.
Really?
Yeah.
Yeah, I would argue that. I think you're right. I think 7 via natural or artificial opening.
But it don't say how he measured it.
Yeah, external would have to be that.
The forehead.
You know,
the forehead.
Yeah.
Or even the armpit. Even the armpit.
Or the armpit. Yeah,
Yeah.
that's good. Or do you remember? I mean, they certainly wouldn't use it in hospital, but they used to have these strips.
Yeah, we used those
on
when I was in high school.
Right.
Yeah, in school, that was how they checked your temperature.
Right.
So it could be external because they could use the little forehead thing to do the temperature, but it doesn't. Wouldn't you query? Because
it doesn't say you got to query.
I would query that, but somebody with an unexplained high fever, you would have to think they would have to use some kind of internal.
I would say
to have
by
the most
mouth.
accurate. The most accurate.
And actually, anus is more accurate.
More accurate.
Yeah.
Yeah, the rectal's more accurate.
Yeah. Rectal. Yes, you're right. Okay. As usual, Jennifer, you are correct.
You know that I always have to come up with a good question.
And I so appreciate it. And you know what? It would help me if you could email that to me.
I'll email it to you. But that was why I was like, when I saw that one, I was like, I would have never even thought that we would have to write a code for checking someone's temperature because it, inpatient wise. Now even outpatient, when you go to the doctor's office, they automatically check it.
Okay. Outpatient, taking the vitals is included in the E&M code.
Exactly. And see, and that's why I thought on inpatient, that would be included in their room and board.
And I agree with you. But you said that the physicians took the temperature, not the nurse.
Okay. Yeah, it says Dr. Hamilton
would
measured
it be because the doctor did it and not the nursing staff didn't do it? So the doctor has to be billed for his
time, and she had she had unusually high fever.
Right.
Yeah.
So that makes it more important. This is not just let me check and make sure you're 98.6 kind of part of vital signs. This is an extra because she has such a high fever. So that makes sense as an additional procedure.
But then that brings another question. If the doctor did it and we're charging for the doctor, shouldn't it be charged not through CM? I mean, not through PCS. It should be a CPT code, correct? Because the doctor's office would be putting that in.
But the doctor, yes, but yes, you were right.
Unless he's a part of the hospital, unless he practices
Okay,
a hospitalist, yeah.
Right. But even if he is not a hospitalist, and even for hospitalists, you use CPT codes.
Okay.
For the physician being there, it would be included in the E&M code. But the ICD-10 PCS code for the hospital part, but more importantly, I would want to make sure that it was documented that this was done for whatever else was going on. I mean, there's no way this doctor came in, took her temperature, and left.
Yeah.
Right. So for those little short ones, we kind of just pulled out sentences because it's really more of a practice. But I don't even know that there would be any reimbursement connected to that.
Okay.
But you would definitely want it documented.
Okay.
And in addition, the hospital has supplies that are being used.
Because I know that when in the ICU, when we have patients that come in, especially the COVID patients, we have to charge them for a regular thermometer.
Right.
So,
and it's all part of that new, about that new CPT code for the new COVID extra supplies for the PPE and everything.
Also charge them for the stethoscope, disposable stethoscopes that go in the room.
Right.
Wow.
Because they have to be one use only.
Yeah, and throwaway.
We're learning a lot. This is great, right? Don't you think we have a worldwide pandemic just as an excellent case study for you guys?
Yeah. And as for you were talking about job-wise, Prisma Toomey was hiring for a coder.
I applied. I hadn't heard nothing from them.
You did? And I said, well, I just started. I said, so it wouldn't, I said, I wouldn't be able to do it because I just started. So,
all right. But that gives you a little view for the future. And maybe Jennifer will get the job. And then your study buddy will be able to interview you when you're done with the program.
That's what I'm talking about, study buddy.
And say, Mickey, okay, let's see. I think lunch at McDonald's could get you this job. No.
I will get you some Starbucks.
Starbucks.
Oh, they got this good thing. Y'all have to try it. It's this green drink. It's made with kiwi. And it is so, I get it with the lemonade because I don't do sodas anymore. Or you can get it with the coconut milk. It's
ooh,
that sounds good.
Yeah.
Yeah.
The coconut milk is one that's good. And also they have one that's called passion fruit guava. I think it's passion fruit guava, but it's with coconut milk. That's delicious.
Oh,
that sounds good too.
And
all right, that's it, ladies. We gotta go. We got a break to go to dinner.
Yeah.
All right. Making me hungry.
Jennifer, I'll reach out to you. I'm off Friday, Saturday, Sunday, so we could. If you're not busy Saturday.
Yeah,
just give me time to go over everything for 35.
Yeah, just
meet at
Starbucks.
Yeah, look.
No, because then I got to wear a mask, and I don't. My mom can't. I'm staying with my parents, and she's not allowed to get COVID. So
my parents.
I'm not allowed.
My parents
I think nobody should be allowed to get COVID, but no, I understand. I have not been out of my house in over a month. I mean, except to go to my mailbox because I get my groceries now delivered. So,
I pick mine up when I get off from work. I go pick it up.
Oh, see, you have to go out of the house to go to work. Yeah. I got to go to work here. So, all right, ladies, stay healthy, stay well.
All right. Y'all have a good night.
Later. You too.
All right. Bye-bye.
Bye.